Welcome to a very special podcast that is part of a series I am leading on diversity and inclusivity with CME Outfitters. Today's CMEO briefcase is entitled Promoting Equitable Oral Health in Patients of Color. I'm Dr. Monica Peak, and I'm a professor of medicine at the University of Chicago. I'd now like to welcome Dr. Maxine Feinberg. She's a periodontist and the third woman to be elected president of the American Dental Association, as well as a past president of the New Jersey Dental Association and New Jersey State Board of Dentistry. Dr. Feinberg, I'm honored and excited to have you joining us today, and I'm really looking forward to the discussion.
Thank you, Dr. Peak. This is really an exciting moment for me. This is a topic that's near and dear to my heart, and I'm hoping that we'll be able to encourage a good dialogue, because that's what we need to facilitate some change.
Absolutely. So let's get started. Let me begin by starting with our first learning objective, which is to apply action steps to eliminate barriers to equitable dental and oral health care in patients of color. So Dr. Feinberg, from the data, we know that oral health disparities can be amplified even more than oral health disparities due to the high cost of access. What can you tell us about the impact of structural barriers to dental care?
Well, I'd like to say that, there are still considerable barriers for people seeking dental care. Part of the problem is, for example, many states do not include adults in adult Medicaid dental benefits. Many of the FQHCs out there do not have dental facilities. And, a lot of people are hesitant to participate in Medicaid, not just because of low reimbursement, but really because there are onerous, they're just onerous requirements and obstacles. For example, we all have, if you want to participate in Medicaid, you need to register. And if there are, let's say, 8 Medicaid providers in a state, you have to provide 8 different applications, which make it just difficult for people who do want to participate. And then again, I think there is a lack of comprehensive understanding between our dental and medical colleagues, and all of these things contribute to the barriers for people to receive the care that they so desperately need.
That's fascinating, because I think a lot of us are aware that there's limitations in dental coverage, and that there are few places that accept Medicaid, but I was unaware of the large bureaucratic hoops that contribute to that's making it difficult for providers to provide these dental services.
Yes, and I think that, believe it or not, I think that is one of the major obstacles. I know a close friend of mine has a pediatric office in our state. She hired a new person to come and work. The person had to apply to 8 different Medicaid provider programs. They had to schedule around when the person was credentialed. So it makes it very difficult. But I think that there should be ways that we can simplify the process. For example, a single form for those who want to participate in Medicaid, I think would increase the number of providers almost immediately. And then slight advances and increases in reimbursement. We've seen it here in the state of New Jersey. When they offered a modest increase in reimbursement, they were able to get many new providers. So there's a lot to be done, but there's a lot we can do to improve it.
Yeah, I think this is a great example of what we talk about when we think about structural inequities. And some of the examples you gave are ways that we can try and overcome them to make healthcare accessible to those who are currently suffering from these kinds of structural barriers. One of the questions that came in already was how we can, as healthcare providers, think about social determinants of health thinking about other kinds of structural inequities like food deserts and poor nutrition, but certainly these kinds of societal barriers that you're mentioning also come into play. So I don't know if you want to address that now, or if we would rather table that, but just put that on your radar that people are interested in also thinking more broadly.
Well, I think that's a wonderful question, and I think that absolutely we do have to look at this in a more organic way. And I think improving oral health literacy among the dental profession and the medical profession, including all providers, school nurses. I can just think of social workers. There's so much we could do to educate the healthcare providers about these problems. I'll always remember I went to visit a dental school in a remote part of the state of Missouri, and the dean of the dental school pointed out to me that like every few feet there was a fast food restaurant, and yet there were no places to buy healthy food. And, it became very difficult for the community to eat healthy. And, it definitely contributes to diabetes and certainly tooth decay. So, there are all of these things that I think we need to start addressing. And again, I think a good deal of it will come with better education.
Yes. And you partially addressed what was our another question that had come in when you said thinking about dental literacy for both not only dentists and dental trainees, but also for physicians and medical trainees. Because one of the questions was from a dentist who said she frequently gets, or he, medical students coming to the rotation. And what are your recommendations for more collaboration between physicians and dentists around education? So yes, there's lots for all of us to learn because the teeth are an organ system in our bodies and don't live in isolation.
Absolutely.
Thank you so much. So one of the best ways to illustrate some of these structural and interpersonal inequities in oral health care is to look at the dental needs of some individuals. So Dr. Feinberg, please take us through our first patient case.
Absolutely. Our first patient, and this is a very common thing, we see in our dental offices, is Rachel, who's 28 years old. She's pregnant. She's had 2 recurrent miscarriages. She's in her 20th week of pregnancy without any genetic abnormalities or poor obstetric history. She has no systemic health conditions and does not take medications. Her BMI is 32. Her previous history of gestational diabetes, I think, is important to us. There is no primary care physician, and she has not received nutritional counseling. She has poor oral health, untreated dental caries. Patient complains of sore gums, persistent halitosis, and reports that she last had a dental visit at age 16 for a toothache. So very often people seek out emergent care, but don't follow through with the more routine care that they need, and this is not uncommon. And she does have Medicaid insurance. So I think these are very interesting. This is a very interesting patient because we wonder if her poor oral health might have contributed to her miscarriages. We do know that periodontal disease can contribute to low birth weight babies. So this is not uncommon. And again, I think that one of the programs that I think is just wonderful, like here in New Jersey at Morristown Memorial Hospital, is where the women who are pregnant get prenatal dental care. And I think that that is really critical. And then after the babies are born, there's follow-up care and the children are eventually brought into the system. And I think that, to me, is the absolute best way to address this kind of problem. So I do think that, again, we need to encourage pregnant women to seek care. We need to get the obstetricians on board with referrals to dental providers for checkups during the initial part of pregnancy.
Excellent, excellent. So before we discuss this any further, we have an audience response. And so Rachel's new obstetrician refers her for a dental checkup. What are the most likely initial findings during an oral health examination that we would expect to see? Number one, abundant plaque within the gingival pocket. Number two, and go ahead and start answering your responses. Number two, mild gingival inflammation. Number three, no bleeding on probing. Or number four, microcavitation in tooth enamel. Okay, so the correct answer is number one, abundant plaque within the gingival pocket. And so half of the audience got the answer correct. So that's great, but it also shows that we have about half of our work cut out for us to do for the rest of the session. So Dr. Feinberg, before you explain the answer and why that's the correct one, can you tell us how Rachel's dental health should be assessed and treated? And let's talk a bit about the effects of oral health care on pregnancy and maternal and infant health.
Well, I think it's incredibly important that during pregnancy, patients be encouraged to see a dentist for a complete evaluation and exam, not only of their periodontal health, but to see if there are any ongoing abscesses, dental infections, root canal infections, and what have you. And it is completely safe to visit a dentist during pregnancy. And so I would encourage early intervention, because the earlier the oral needs are addressed, the less likely that there'll be serious sequela when people don't have treatment. So they'd go to the dental office, the dentist or periodontist would do a complete oral exam, check all the tissues, measure the pockets, check for bleeding, and look for all those other things. And if necessary, take x-rays to rule out for serious dental infections. It is very safe during pregnancy to have an x-ray or x-rays taken. Patients are shielded with lead aprons. If they need treatment, it's perfectly safe to receive dental anesthesia. I would recommend getting cleanings done probably every 3 to 4 months during the pregnancy, because inflammation is much more significant in pregnant women, and we want to avoid things like pregnancy granulomas and what have you. So just a thorough exam followed up by regular routine cleaning visits as needed during the 9 months.
Great. So I think we're ready to move into our next patient case. So our next patient is a 9-year-old, Maria. Dr. Feinberg, let's talk about this child's oral health care needs.
Very good. And I don't think this is an uncommon scenario. We've all seen similar cases in our offices. You have Maria, who's 9 years old. She has rampant caries in both her primary and, unfortunately, her permanent dentition. She's missed school due to dental discomfort and pain. And she does have Medicaid insurance, but her aunt had difficulty finding a provider. And once again, I think it depends on where you're located, but very often it can be difficult to find a provider who is in close proximity to where the patient lives. Technically, if it's a managed care, if they're managed care providers, the managed care provider should also help the parent or guardian find a provider within their network. In some cases, they're actually assigned a provider. But again, we need to see more FQHCs with I think dental clinics. It would be great if we could increase the number of residency programs that include, for example, pediatric dentistry. All of these things would be very helpful at making it less difficult to find a provider. But when we look at Maria, I think it's unfortunate because, once again, this is not a matter of not having coverage. This is a matter of finding coverage and gaining access. Believe it or not, sometimes the problem is finding transportation to the dental office. In rural areas, it's very difficult for people to find. In certain rural areas, it can be very difficult to find a provider. And then, understand that public transportation is not readily available in all communities. So these are just some of the barriers that make it difficult for, let's say, Maria's aunt to find a person, a dentist, to provide help for her. And this is why I also am a firm believer in school-based programs. The idea that kids could get dental care at school makes it so much easier, even if it's just a sealant or a fluoride program. All of these things help reduce the caries rate and improve our delivery of care to this young population.
Great. So let's poll the audience again about oral health in children. So which is higher in children, the rate of asthma or dental caries/cavities? So first, asthma, number 2, cavities, or number 3, the rates are similar. And so we'll give you a few minutes to respond. All right, so we might think that because we're having a talk about oral health that the answer would be cavities, but it's actually asthma. And so because asthma is so prevalent, but that doesn't mean that the oral health prevalence isn't still significantly high. And that, again, oral health is not related to so many systemic diseases that we as children and adults face. So, Dr. Feinberg, the very devastating effects that poor oral health can have on children often go unnoticed. What can you tell us about this health disparity, and how do we help children receive good dental care?
Once again, I think that education and cooperation between our medical and dental colleagues is so important. When you look at the number of missed school days every year, and we're talking millions of days of missed school throughout the country because of dental infection and pain, I think we need to do more to encourage cross. When you look at the number of patients who see a pediatrician but don't see a dentist, if we can encourage cross-referral, where, for example, school nurses and pediatricians are making early referrals. Children should see a dentist before, at their first birthday. People have this misguided understanding that it's, like when they're 4 or 5 years old. Well, by then, many of these children will have a mouthful of caries. So earlier referrals are incredibly important. Working with the various managed care companies to ensure that children have a dental home is so important. We know that if children do have a dental home, they will suffer from a much lower incidence of caries and general better health. If you're in pain, you're going to eat a softer carbohydrate-laden diet, chances are. So I think that the earlier we get children into a dental office, the better the results are. And once again, I think that we need to look at our safety net for those children who don't have insurance, although the Affordable Care Act does cover children, which was a major game changer and really improved the numbers over the last 5 or 6 years. But again, I think it's going to come down to better referral relationships and better education about oral health.
And let me actually correct my own self. So the answer that everyone else got for 97% was correct, and that dental caries are more common than asthma. So your initial gut feeling was correct. So as this slide shows, the dental caries are the most common childhood disease, 5 times more common than asthma. And I will say that I'm an adult provider, not a pediatrician.
Well, what I was going to tell you is, and depending on the age group, for example, it's not just in very young children. In the 6 to 11 range, it's extremely high, but even in the 14 to 17-year-olds, they're basically 4 times more likely to have dental caries than asthma. So I think this is something that is really an unfortunate statement, because dental caries is preventable. Asthma may not be preventable, but dental caries is preventable. So we should be seeing much less incidents, because once again, with proper oral care, oral hygiene, diet, improvement in diet, and water fluoridation, we should be seeing a much lower incidence of dental caries in children.
Absolutely. So I'd like to invite you to talk a bit about prevention for dental care.
Yeah, this to me is so important. And, one of the things I've been very proud of over the years as a dental provider is we've always taken great pride in being a profession that looks to prevent disease. And again, I think there are many things we can do to, improve the numbers that exist. Again, I live in the state of New Jersey, which has very poor community water fluoridation. I know for a fact that if we were to provide community water fluoridation, the numbers in my state would improve dramatically. Perinatal dental care, I can't say enough that if we had a pregnant woman into the dental chair, aside from the benefit to her, it's the education, it's the awareness, and then to continue once the baby is born, to ensure that they continue to seek care for their children, I think is going to be a huge game changer if we can really start to make this the norm and not the exception. Postnatal dental care, as I said, once you have the mother in the chair and you've had the opportunity to better educate her, there's a much greater chance that she will take her children. Again, we need to talk to the people who are providing the school lunches and what have you, because the healthier the diet, again, the less likely that you're going to see massive amounts of caries. But when you're giving kids nothing but, sweet drinks and carbohydrate laden, one of my favorite terms, diet, you're going to see an increase in dental caries. Again, we need to improve the literacy, the oral health literacy for not only parents, but teachers, school nurses, principals, pediatricians, and social workers. I think social workers could play an incredible role in making sure that children are getting to a dental appointment. Also, again, as I said earlier, there are programs. We have a program in New Jersey where pediatricians can apply fluoride varnish to children's teeth and be compensated, which I think is a wonderful idea. But they also are encouraged to find a dental home for their patient. The program has been very successful. I'd love to see it in all 50 states and, all of the territories, because again, this type of collaboration does pay off in the children's best interest. And then, for example, in Newark, New Jersey, the Boys and Girls Club, which is a really safe place for children, has a volunteer dental clinic. We've seen that to be very effective. when children come in after school for social programs, but at the same time, we've made dental care available to them. It just really does pay off in a large way. And then, of course, I think that we need to just make dental Medicaid a little more user-friendly and give incentives for dentists to participate. And I think all of these things could really make a huge difference in the overall health of our children.
Yes. There have been a lot of comments and questions coming in, so aligning with this theme of how we can help engage the community, and suggested methods like using dental hygienists to provide some of the school-based preventive dental services. What about the role for dental therapists in improving access to care? How we can get parents to think more positively about the idea of fluoride and how it can be healthy. How we encourage patients or people of color to become dentists to sort of address some of the issues around trusted messengers and trusted providers. So a lot of good feedback coming in the chat from the Q&A, aligning with these very things that you're talking about, essentially needing to enhance the workforce, to build up capacity and trust within the workforce, and to think more broadly about who is part of the workforce to get all of this work done that we need for prevention and treatment.
And I think these are all great things. In fact, a little later on in the program, we'll discuss some of the disparities in the numbers of underrepresented minorities in the workforce. And I, once again, believe that increasing those numbers would be a huge help in terms of improving dental care. People, it's just been shown in study after study that people feel comfortable seeing practitioners who resemble themselves and who they can relate to. So I think that that is something that really needs even further discussion, because the numbers are not improving as much as we'd like to see them improve.
Great. So now let's shift to the other end of the age spectrum and talk about elderly adults. And they're another vulnerable population in oral health care disparities. So let's look at a patient case with Dr. Feinberg to help illustrate this issue.
And again, Edward, not an uncommon patient that we see in our dental offices with similar scenarios. Edward is 67 years old. He has poorly controlled diabetes for over 19 years. He has generalized periodontitis, severe loss of periodontal bone support. His tissues are extremely swollen. Generalized separation was noted. The teeth are mobile. He has pain on chewing. He's subsiding on a soft carbohydrate-laden diet. His recent A1C levels were elevated, as were his daily blood glucose levels. And he requires full dentures, as none of his dentition could be maintained. So I think this is an excellent patient to discuss, because it's more common than we'd like to admit, because, you know, certainly we'd like to see people get to old age and have a full dentition and have a healthy dentition. And while certainly those numbers have improved over, you know, the last century, we still nonetheless are faced with patients like Edward who, due to, again, possibly difficulties in finding dental care, he may not have Medicaid, because depending upon the state you live in, it will or will not cover dental care in the 67-year-olds. As of now, Medicare, except for some of the Advantage plans, do not cover dental, although Congress is looking at that as we speak. But again, I think earlier intervention and better education, you know, if Edward's physician and diabetic educator possibly had sent him, you know, 19 years ago to seek care, we might not be having this discussion, because we do know that with care, diabetics respond very well. And so the earlier the intervention, the better the outcome. So again, I think that this is an important age group and an important scenario for us to be discussing today.
So, really an excellent case for so many reasons. Can you talk a little bit about this overlay? Because Edward is someone who has diabetes, which disproportionately affects African Americans and other racial and ethnic minorities. He's got, the issues going on with his dental disease. Those two overlap, and so so we can see just the interactive effect on health for racial and ethnic minorities who are disproportionately burdened with these kinds of diseases. Can you talk a little bit about the disparities for a case like this?
There's no question that people of color suffer from a much higher rate of many things, not only diabetes, but for example, hypertension. Mm-hmm. And again, these are things that when you look at the numbers of patients who, let's say, visit a dentist but don't visit a physician every year, if the dentists were doing checking A1Cs in their office, if the diagnoses were made earlier, if we had better community numbers of community providers, if we had again better communication and education, I think we'd be able to address these problems much sooner, because, we do know that, for example, if you're a diabetic and your oral disease is controlled, we can reduce your A1C by almost a half a percentage point. We know that, for example, if a diabetic gets regular dental care, they will not only see less hospitalizations, but also their costs for their medications will decrease, because again, early intervention means better health for all communities. But again, I think we need
I'm going to stop you right there.
Sure.
Because we're going to bleed into our audience response question.
Okay.
So before we go any further, let's get into the question, which is, how does diabetes affect oral health? So
Sorry about that.
No, that's okay. So our first question is, having diabetes does not affect oral health. So I guess no one's going to answer that one.
I gave away one answer.
No problem. Number two, patients with diabetes may require more local anesthesia during dental procedures. Number three, patients with diabetes are twice as likely to have periodontal disease. And number four, patients with diabetes are 3 times more likely to have dental caries. And so I'll give a few minutes while we mull over those options and you guys choose. All right. So the correct answer is number 3, which the majority of us got, and no one answered number 1. So that's excellent.
Thank goodness.
Also. All right, so Dr. Feinberg, let's talk a little bit more now about the linkages between diabetes and oral health, as you had already started. Yes. So I'll let you continue that discussion.
Well, there's no question that, individuals with diabetes are 2 times more likely to have periodontal disease. And when you consider that 9.3% of our population have diabetes, this is a significant number. And the CDC is predicting that by 2050, 1 in 3 adults will have diabetes. And as we discussed earlier, this will impact people of color at a far greater percentage than the rest of the population. A 1% improvement in glycemic control can reduce mortality by 21%. Now, that's huge to me. And dentists can help reduce glycemic control, improve glycemic control by 0.4% with just regular dental care, cleanings on a regular basis, what have you. And, one study showed that there is a link between the numbers of missing teeth and as an excellent indicator of prediabetes. And my own, one thing that I have to say that's been a big game changer, for 35 years, I have instinctively known this to be the case, but only until recently have we had the actual data, the scientific data to support it. And now that we have that data, I think it's important that we pay attention to the data. You could reduce medical costs, just by, again, making sure people get routine dental care by almost $3,000 and reduce hospital admissions by almost 40%. So I think clearly now is the time for us to really amp up the dialogue and start trying to make a difference. People who were fortunate enough, I think, to have dental insurance throughout their working careers are probably more inclined to see dentists even after they retire and as they age. But my feeling is that very often people in underrepresented minorities may not have had that advantage because very often they work in lower paying jobs. They don't necessarily get benefits. So again, I think making dental benefits available to all people will make a big difference. And the earlier we get people started, once again, I think the outcomes will speak for themselves.
Yes, the outcome of hospitalizations reduced by almost 40%. I had not seen that number, and that takes my breath away. So that's a significant number for patients, for medical costs, for hospital capacity right now, as we're thinking about, trying to create space given where we are with the COVID pandemic. So super important numbers.
Absolutely.
Yeah. So, all right. So let's keep moving.
And again, talking about how this scenario could have been avoided. Again, it's making affordable dental care available to people. Education is so important, especially in vulnerable populations. Getting to work with primary care physicians, endocrinologists, diabetic educators, social workers, all of these things make a huge difference. But, for example, the ADA CODA, which is the accrediting body for dental schools, requires interdisciplinary education, as does the people who accredit medical education. But the programs are really fluff. I think in order to make a difference, we need to look at the curriculum and figure out a way to make it more robust on both sides so that dentists understand what their role could be in the team and physicians know that they can work with their dental colleagues and refer in a way that will be mutually beneficial and ultimately improve the patient outcomes. I think that we need to also educate caregivers. I treated nursing home patients for a year in a mobile dental van, and it was heartbreaking to me because in the facilities, there wasn't even the most minimal oral care available. I mean, people didn't have toothbrushes. So we need to work with the population that are in facilities and educate the caregivers there at the absolute importance. I'll give you an example. How many times do we hear of a person who's institutionalized and they get hospitalized for pneumonia? Well, it's been shown that we can reduce the incidence of pneumonia, again, by improving the oral health, because the mouth is just a, it's a bacterial haven. And so if we can reduce the harmful bacteria, we can make a huge difference, once again, I believe, in the overall health of that very vulnerable population. So there's just so much we can do. And I look forward to, again, starting the dialogue and finding the action items we need to make this reality.
There's a question from the audience, which is going to probably link into your next slide, but it's asking about resources for elderly patients on Medicare for free or subsidized dental care. And so what can you tell us about coverage for health insurance coverage for the elderly for dental services?
Well, I think that, for example, many people are eligible for Medicaid and they don't even know it. So I do think that they should look into that, because once again, like our state has a very robust adult Medicaid program, and we provide comprehensive care to adults who are under the poverty level. And so I think that that's something. 2, FQHCs, which now exist in almost every community in almost every state. Many of them have dental clinics that have, and they are required by law to have a scale, so that people who are in the lower income levels are able to receive very good care, but at reduced rates. I think that also people should look at the Medicare Advantage options that some providers have in some of the Medicare plans. Again, it provides some dental care. There is also low-cost dental insurance for people who are retired and don't have insurance. But I think that, once again, another wonderful place to go are hospital residency programs, where people receive excellent. I teach at a residency down at the Jersey Shore. They provide free dental care once you've qualified for charity care. So people, there are safety nets, but I think we need to expand the safety net, to be honest with you. We need more programs like my Jersey Shore program, where they'll help get quality dental care to the most vulnerable people. Great.
Let's switch now to thinking about the healthcare workforce, because I know we're getting short on time, and talk about, you've mentioned the need for medical dental collaborations, and can you tell us more about this, as well as the need for more diverse oral healthcare professionals, because that's come up a lot in the Q&A, and I know there's a lot of interest in this. We're getting short on time, but I did want to make sure that we just in a minute or so covered that.
Well, I think this is an incredibly important topic, especially when you consider that, for example, looking at dental school application rates, the numbers for underserved minorities in general hasn't risen that much in the last 20 years. And then when you look at, for example, if we were to try to achieve parity, which I think is an interesting concept to think about, we would need an additional 20,000 African-American dentists. We'd need an additional 30,000 Hispanic or Latino dentists, and about 3,000 additional dentists from Native American communities to achieve some sort of parity with the population. But we also know that that's not going to happen anytime soon, because, again, the admissions rates are at about 5% now, and that's not going to really affect the outcome numbers in a big way. So, for example, there are what I refer to as programs that look to improve the pipeline. So the pipeline programs have existed for many years. Dr. Jean Singford, who was dean at Howard Dental School and was actually the first woman dean of a dental school, has been working on this since 1998. So it shows you that this problem is very difficult to address. And I think part of it is we need to start earlier. You can't wait until high school. You need to start in elementary school. We need to get dentists of diverse backgrounds going in for Dental Health Month to show the students that this is a possible pathway for themselves.
We're going to have to end it there. I'm sorry, we're at 11:45.
That's okay.
And so yes, we need to start early and think about the entire pipeline and collaboration and think about how to get more dentists of color into that pipeline. Thank you so much, Dr. Feinberg, for your wonderful time today. It brings us just to the end where we think about our SMART goals that each of us can play in implementing efforts to help end oral health disparities in the United States. So our SMART goals for today are number one, to identify and expand best practices to address structural and interpersonal racism in oral health care. And number two, optimize holistic oral and systemic preventative care and treatment to address patient needs. Number three, improve oral systemic collaboration between dental and non-dental health professionals. And last, to increase the number of place-based total health care encounters with a dental component, including screenings, referrals, and resources for community oral health care. So please join me here at CME Outfitters for our upcoming podcasts and activities with more action steps against health disparities. You can find out all about the upcoming live events and view previous ones on the DNI Hub at the link here. In particular, two of our upcoming briefcases will examine diversity and inclusivity in two important areas, maternal health and cardiac arrhythmia. We will be adding new content every month, and we really want to hear from you, our audience, on what you need so we can make an impact on these important areas. Please remember to collect your credit for today's activity using the Apply for Credit button on your screen. Again, thank you so much, Dr. Feinberg, for your input today. It's been wonderful. And thank you to our audience for all of your work in providing equitable and holistic care to patients around the globe. Thank you.